up we have two ladies presenting for us. We have Dr. Kristen Glenister and Tessa Archbold, who are from University of Melbourne and will be presenting on enhancing integrated care for people living with chronic obstructive pulmonary disease in a regional Victorian setting.
Thank you. Thank you, Hannah. We'd like to begin by acknowledging the traditional owners of the land on which we meet and pay our respects to elders past, present and emerging. And may some of the work we discuss here go to improving the health outcomes of all Australians. So, chronic obstructive pulmonary disease is a chronic lung condition and the fourth leading cause of death globally. It is caused by smoking or exposure to other lung irritants, such as dust or pollution. So as COPD progresses, quality of life deteriorates, lung function declines, and there are more frequent exacerbations, often requiring hospitalisation. So optimal care for COPD is based on care that is integrated, coordinated, patient-centred, delivered by a multidisciplinary team and based on self-management. So in a rural area, care for COPD is often provided by a smaller, more generalist team of health professionals, and care may be difficult to navigate or poorly coordinated, but long-term relationships with health professionals and social support can overcome some of these challenges. So this project was initiated in response to local increases in the prevalence and complexity of chronic conditions, particularly COPD. And we would like to thank the ongoing support of the Murray Primary Health Network in this and the preceding project. So North East Health Wangaratta is a sub-regional hospital with approximately 200 beds. It's located in Wangaratta, which is a town of approximately 28,000 people. It's located in northeast Victoria, approximately 3 hours from Melbourne. And North East Health Wangaratta has a catchment of approximately 90,000 people. So care for patients with COPD in this region is delivered by general practitioners, general physicians and allied health professionals, and pulmonary rehab and maintenance programs are both available. So North East Health Wangaratta is located within the Murray Primary Health Network, and within this network, potentially avoidable hospitalisations for COPD are above the state average. The Central Hume region is one portion of the Murray Primary Health Network and covers the local government areas of Alpine, Benalla, Mansfield and Wangaratta. And 3 out of 4 of these local government areas have above the state average impact of chronic obstructive pulmonary disease as measured by the rate of admission multiplied by the average bed days. So potentially avoidable hospitalisations are relatively easy to measure and give an insight between the interface of primary and secondary healthcare. And potentially avoidable hospitalisations for chronic conditions are thought to be able to be addressed by timely and appropriate access and management in a primary or community health setting. But the issue is complex. Chronic conditions have developed over many years and are associated with factors which are not easily influenced by within the healthcare system, such as socioeconomic disadvantage, prevalence of disease and health behaviours. So this project aimed to engage local health professionals and local patients in devising local feasible solutions to these issues. It also aimed to identify system issues related to organisation of healthcare from both the health professional and patient perspective, and ultimately had the aim of reducing potentially avoidable hospitalisations and ED presentations for COPD to North East Health. So the project used multiple sources of complementary data, including hospital admission, ED presentation, GP data, surveys of both health professionals and patients, and patient interviews. The voices of health professionals and patients were included at each step within the project and included the data collection, the interpretation, and the design of the solutions. So the GP data was extracted from the primary health network databases from consenting GP practices in the region and included such things as the prevalence of COPD, rates of immunisation, GP management plans and team care arrangements, smoking status, demographic information, and after-hours GP service provision. And our understanding is that this was the first time that this data had been used in this way. So the multiple sources of data provided the key findings, and these key findings were then considered by a reference group comprised of 18 people from a range of different backgrounds, including a range of different disciplines of health professionals, consumers, researchers, and representatives from the PHN. The reference group then interpreted these findings and designed the interventions. I'd like to now hand over to my colleague Tessa to tell you about some of the findings.
So I'll talk about some of the findings. So the survey and interview data, as Kristen mentioned, was themed into categories, and these were taken to the project reference group to prioritise the next steps. And some of the major themes included gaps in coordination of care, difficulties during transitions of care, and interagency communication. Based on the findings, the reference group were tasked with prioritising interventions using a high feasibility, high importance matrix, looking at what was important and achievable within the project timeline. Interventions included these listed up here: a COPD cycle of care, development of a COPD model of care, development of a transition officer position, and a patient-held booklet. Today for this presentation, we're going to focus on the transition officer and the booklet because we've just got a 15-minute session. So the transition officer was a nurse navigator type position based at North East Health Wangaratta within our hospital admission risk program. The role was to link hospital, general practice and social services, provide patient education, and the eligibility was all patients admitted or presenting with a primary diagnosis of COPD within the project timeframe. And it was a little bit similar to the coach sort of program that we heard about a little bit earlier today in that sort of nurse navigator type support. The patient-held booklet, I've got a copy of it here, was a paper-based patient-held record designed to empower patients to self-manage, share information and allow the patient to have access to written information about their condition. It was in addition to the usual hospital patient record, and it was designed to align with the My Health record, so there were prompts within the paper-based booklet that would indicate where information was included in My Health record. So looking at some of the results, our evaluation looked at a number of aspects. So the first thing I'll talk about is emergency presentations, hospital admissions and after-hours GP services. So we looked at pre-data, which was 2015-16 data, and then looked at some 2017-18 data. So in 2017-18, there was a decrease in emergency department presentations and a significant decrease in repeat presentations. Hospital admissions were slightly higher and repeat admissions remained stable. And so with this, this wasn't looking at one intervention, it's sort of looking across a number of different interventions at the same time. So looking at after-hours GP services, there was almost equal numbers presenting within GP hours and after hours, suggesting that GP availability may not have been the primary reason for ED presentation. Another part of the evaluation was looking at feedback from patients. So it was a patient survey which was sent out to all patients who'd seen the transition officer, received a booklet or attended pulmonary rehab at North East Health Wangaratta. The transition officer saw 62 out of 89 eligible patients during the study period. The survey was only returned by a small number, but the patients who returned the survey and saw the transition officer typically reported receiving all of the information they needed in the areas of medication, discharge, help at home, contact details, and breathing. The booklet was evaluated using the same survey, so there were specific questions relating to the booklet. So 154 booklets were distributed during the project, and 18 surveys were returned by patients who reported receiving a booklet. Most patients reported the booklet made a helpful difference in managing an exacerbation, understanding medications, and communicating with their healthcare team. And 40% said it helped with understanding breathing difficulties. We then looked at an evaluation from a health professional perspective, and to do this we sent out a survey to all health professionals involved in the care of patients with COPD. So to do that we sent it to organisations within the area who then distributed it within their teams, and health professionals then did an electronic survey. 28 responses were received, and the results suggest that more work may be required in awareness and rollout of the interventions to health professionals. But the interventions were designed with patients in mind and to benefit patients directly. Positive comments included a clear, consistent point of contact during discharge in relation to the transition officer, more efficient referral processes, the booklet being a valuable tool to assist in self-management, and the booklet depending on the client's proactive use of the booklet. So there were some limitations and learnings with this work. So some of the limitations include the small sample size and the relatively low survey response rate. But as we've heard throughout the conference, evaluations of integrated care are complex. Learnings included, so one of the valuable things we did find were patients seen by the transition officer had a very high uptake of referral when they then went home, and patients seen by the transition officer were seen by the transition officer on the ward and then followed up at home. And so we attributed this to a flexible approach allowing face-to-face contact. And so this has led to changes in the service delivery within the hospital admission risk program. And so an outcome has been they're now seeing patients prior to discharge on the ward, which they found increased the uptake of their service. There's more learnings around the value of local solutions and engagement. And so the involvement of the reference group and developing solutions for the local context. So in conclusion, complex chronic conditions such as COPD develop over a significant period of time. Hospital admissions and ED presentations may be unable to be changed in the short term. Some interesting and encouraging findings on the benefit of a patient-held booklet and transition officer role on patient self-management. We found lots of value in partnerships, engagement, communication, multiple sources of data, and multidisciplinary input. And integration is a complex activity that occurs in context. And so looking to the future, we're looking into some digital platforms to support patients. So that might be our next presentation. So we'd like to thank the project reference group who provided a great deal of input into this work, the study participants, and the support and funding of the Murray Primary Health Network. Thank you.
Thanks, Kristen and Tessa. We have time for one quick question if anyone had one? Yeah.
Thanks for your presentation, girls. It was great. I was just interested to know what some of the barriers to the booklet were from the healthcare professionals. Why didn't they like it?
I think, as Tessa alluded to, that there may have been some sort of time lag in the awareness and the rollout of the booklet. So I think that there was more work to be done around the health professionals' awareness of the booklet and how they needed to engage with it. But I think we may also need to do some more work around the patient's readiness or willingness to kind of put it forward as a tool. I think that in some situations the patient wasn't confident enough to put it forward, and they might have been waiting for the health professional to say, hey, have you got one of those booklets? Can we work through it together? Yeah.
So the book was developed with the project reference group, which included a number of health professionals and some patients or consumer representatives as well. So it wasn't so much in the feedback that they disliked the booklet, it was more if they found the booklet made a helpful difference in managing the patient's condition. So it wasn't so much that they disliked it, but they didn't necessarily rate it highly in making a very helpful difference, but in saying that there was positive comments. And the health professionals that answered the survey, not all of them had actually had content, like not all of them had even used the booklet. So, yeah. Thanks.
Thank you. Please join me in thanking Tessa and Kristen.